I'd like to share with you a case of Cypass implantation followed by Kahook Dual Blade after phacoemulsification and toric intraocular lens placement. This patient is a 64-year-old African-American male with primary open-angle glaucoma and a Tmax of 26. His pre-op IOP was 21 on Xalatan, Cosopt, and Alphagan, with a mean deviation of minus 11.28 decibels on Humphrey visual field, with progressive loss documented. We have just completed cataract surgery and implanted a toric IOL. We are now implanting a Cypass supraciliary implant with visualization from a TVG gonio lens. The scleral spur is identified and the Cypass applicator is passed easily into the supraciliary space. The implant is released from the applicator just short of its goal and then gently tapped into its final resting place. Instead of stopping there, we are electing to add a second minimally invasive glaucoma surgery to the Cypass implant. In this case, we are using the Kahook Dual Blade to allow aqueous an additional route of egress out through Schlemm's canal to augment the flow going into the suprachoroidal space through the Cypass. This patient has severe field loss and was uncontrolled preoperatively on maximum medical therapy. We would like robust IOP lowering, but would also like for rapid visual recovery and minimize short-term and long-term risk for complications to this his better seeing eye. We are looking to achieve this by combining these two different forms of minimally invasive glaucoma surgeries in hopes that in combination they will work better than either surgery alone to provide IOP lowering comparable to traditional filtration surgeries without all the risk. Traditional Kahook Dual Blade technique employs cutting from the periphery to the center from either side to meet in the middle, allowing for excision of a strip of trabecular meshwork. This technique is good, but it actually limits the amount of trabecular meshwork you can remove. So instead, in our case, we are starting from the center and cutting out to the periphery as far as the gonioscopic view will allow to enable us to unroof as much of Schlemm's canal as possible. The gripping action of the TVG gonio lens allows us to rotate and torque the eye to enable even more removal. Once we've cut as far as we can in one direction, we turn the blade to face the opposite direction and once again cut from the center to the far periphery as far as our view will allow. This should allow us to unroof about 120 degrees of nasal Schlemm's canal to maximize access of aqueous to collector channels. We will now use Inamura cross-action capsulorhexis forceps to remove the free-floating strips of trabecular meshwork from either side of our Kahook Dual Blade excision site. Upon completion, a nicely positioned central Cypass is seen, paired alongside broad swaths of excised trabecular meshwork, revealing the stark white of the outer wall of Schlemm's canal. This patient's intraocular pressures over 3 postoperative visits on day 1, week 1, and month 1 were 9, 10, and 10 on no medications. These great results were achieved with very little added time or risk beyond the cataract surgery alone, and allowed for rapid visual recovery in this monocular patient. Thanks very much for watching.